V1, V2, V3, V4, V5, and V6. Then we have right-sided ECG, where we put the lead V3, V4, V5, and V6 at the right side, and also the posterior ECG. Okay, so this is ECG graph paper. So horizontally, one small box is 0.04 second, and one large box is 0.2 second, and vertically, one large box is 0.5 millivolt. So this is the normal calibration of ECG graph paper, 10 millivolt per second or 25 millimeter per second. So to me, I always told my my junior doctor, my junior colleague, my student, ECG is just like a ABC, because it's A, B, C, D, E, F, G, O, P, Q, R, S, T. So first we must know what is P wave. P wave is the first positive deflection of the ECG. Then the first negative deflection is Q. Then the second positive deflection is R. Then the second negative deflection is S wave. Then the third positive deflection is T wave. Then if fourth deflection is U wave, before we have a P wave again. So P, Q, R, S, and T wave. This is very basic. I hope everyone know this. Then after that, there is a PR interval. PR interval kita tengok from the start of the P wave, start of P until the beginning of the Q wave. So we call it PR interval. Then this is a QRS interval, beginning from the Q wave until the end of the S wave. Then this is the ST segment. Then this is the duration of T. Then we call this one is QT interval. So the PQRST. So what happened during P wave? Actually, P wave means atrial depolarization. Mean this is the electrical depolarization of the P wave. But this one is for electrophysiologists. They understand P wave as atrial depolarization. But for general knowledge, P wave is considered as atrial contraction. Then QRS is ventricular depolarization, or for general understanding, QRS compact is when the ventricle contract. Then T wave is ventricular repolarization, or for general understanding, T wave is a ventricular relaxation. So I know during walk around or during bedside teaching, we always ask about axis determination, left axis deviation, right axis deviation, or normal deviation. So it's very easy actually. We just look at the lead 1 and lead 3. It will be right axis deviation if the lead 3 is positive and the lead 1 S wave is deep. Then in left axis deviation, the lead 1 R wave will be very positive, and the S wave in lead 3 will be very negative. Any question on this part? The question I will complete.
No.
So another thing, we can calculate the heart rate from the RR interval. I don't have the example here. So we just see the RR interval, the number of big boxes between the RR interval. So we just divide 300 to the number of tick boxes of the RR interval. So let's say in between the RR interval, as example, is ECG. So we just calculate the numbers of tick boxes in between 2R. Like here, there is a 1, 2, 3, 4, 5, and about 6. So 300 divided by 6 is about 50. If you want to remember, just remember like this. If one boxes, the heart rate is 300. If two boxes, the heart rate is 150. If three boxes, the heart rate is 100. Then we come to right ventricular hypertrophy. So this is the definition of right ventricular hypertrophy. So there's a tall R in the V1. The R is much bigger than the S, or R to S ratio is more than 1 in the lead V1. And there is deep S wave in V4, V5, and V6. So usually the right ventricular hypertrophy is quite rare. But most importantly, you must able to identify left ventricular hypertrophy. So usually in left ventricular hypertrophy, in lead V1, there will be deep S wave. And there is deep S wave in the lead V1 or V2. And there will be a tall R wave in the lead V5 and V6. And we will use the voltage criteria. Voltage criteria means the summation of the S wave, whether in V1 and summation of S wave in the V1 and R wave in V6 lead, or summation of the lead V2 plus R wave in lead V5, there will be more than 7 big boxes. So you calculate like here, there will be 1, 2, 3, 4, 5, 6, 7, 8 boxes. The summation of the S wave and the R wave in the V1 and V6, or summation of S wave in the lead V2 and also R wave in the V5. So if more the summation is more than 7, we classify the patient as left ventricular hypertrophy. So there are two types of left ventricular hypertrophy: the pressure overload type and also the volume overload type. In pressure overload type, there will be ST depression. Then V4, V5, and V6. While volume overload, there will be tall R wave in the lead V4, V5, and V6. And they must fulfill the criteria of the voltage criteria. Means you must sum the S wave in the V1 and the V6, or the S wave in V2 and the V5. Then we come to the ischemia in infarction. So ischemia, there is a subendocrine ischemia or transmural injury. So subendocrine ischemia will lead to ST depression in ECG. However, in transmural ischemia, there will be ST elevation. So there are a few types of ST depression that you will encounter when you see or interpret ECG. There will be a downsloping ST depression, upsloping ST depression, or horizontal ST depression. So in short, anything upsloping up is good, anything downsloping or horizontal is considered as ischemia. And is an indicate a significant ischemia of the cardiac muscle. Then this one you must remember by heart. There's no easy way to remember this, but this is how usually I interpret ECG. So when I see a ECG, I will see the ECG according to the ECG territories. First, in my personal practice, first I will see the lead 2, 3, and AVF, which will indicate the right coronary artery or the inferior myocardial wall. Then after that, I will see the 1, AVL, V5, and V6, which is the lateral, indicate the lateral wall of the myocardium, which usually supplied by the circumflex artery. Then after that, I will see the V1, V2, V3, and V4, which usually supplied by the left anterior descending artery of the anterior myocardial wall. Then last but not least, you must always see the lead AVR, because it's important to see lead AVR. If we have ST elevation in lead AVR and ST depression, more than 7 lead ST depression in other lead, it will indicate a left main artery stenosis or occlusion. It means it's suggestive of very massive infarction. So as example here, we have the ECG of probably this patient with ST elevation over V1, V2, V3, V4, V5, V6, and also the 1 and AVF. There's also some ST depression reciprocally at the lead 3 and also AVF and also the AVR. So this patient has what we call, you can call anything. You can call this tombstone, the batu nisan, tombstone that the Chinese always put their cemetery. Or we can call it shark fin. The shape look like a shark fin. So you cannot miss this kind of ECG. And if you see this kind of ECG, you must make a quick decision that this patient has a extensive anterolateral MI, then you need to whether thrombolize the patient or send the patient for primary PCR. Or if you are a houseman or in the ward or in emergency department, you must alert your MO or specialist immediately. So let's say if a houseman call me straight away with this kind of ECG, I will never scold them. So what is ECG? So my approach is now, we first see it 2, 3, and AVF. So as we can see here, there's a ST elevation in the probably lead 3, AVF, probably some ST elevation, one box in the lead 2. Then I will see the lead 1, AVL, V5, and V6. And as we can see here, there is a ST depression in the lead 1 and AVL. Then after that, I will see the lead V1, probably there's some ST elevation here, V2, V3, V4, and also last but not least, I must see the lead AVR. So as we can see, there is a ST elevation in the lead 3 and AVL, and some ST depression over the lead V2 and tall R in the lead V2. So if you see a patient with ST elevation, or you suspect a patient with inferior MI, like this patient, you must order the right sided ECG, look for any ST elevation in the V4R, V5R, or V6R, and also the posterior ECG, the lead 7, V7, V8, and V9. Look for any ST elevation. So the complete diagnosis for this guy is inferior posterior MI with RV involvement. That's how you interpret the ECG with ST elevation in the inferior lead, right-sided lead, and the posterior lead. Inferior posterior MI with RV involvement. So when you encounter any patient with acute MI, it's very important to classify the patient whether the patient in Killip 1, Killip 2, or Killip 3, or Killip 4. Because it will recertify the patient whether the patient is higher risk or at the low risk. So Killip classification is very easy. You just listen to the lung. So if the lung is clear like the patient just now, means the patient is Killip 1. And then if there is a bivascular crepitation on lung auscultation, we classify it as a Killip 2. And if there is a generous crepitation on lung auscultation, so the patient is in Killip 4 and patient in Killip 3. Then if the blood pressure is low and patient require inotrope, we classify them as cardiogenic shock. So why Killip classification is very important? It will prognosticate patient with acute MI. So if the patient is in Killip 1, usually the prognosis is very good and the mortality rate is very low. So if the patient in Killip 3 or Killip 4, usually the prognosis, the mortality rate can approaching almost 100%, 50 to 100%. So it's very important whenever you want to refer to cardiologist or anyone else, you must classify, tell your superior regarding the Killip class. So example, when you call me probably from your district hospital, I have a 50 years old smoker who presented with chest pain. You must tell them the cardiologist or specialist the onset of chest pain, the duration of chest pain. 50 years old smoker, chest pain started 3 hours ago, 1 hour ago, Killip 1. Then you must tell the ECG whether it's inferior MI, extensive anterolateral MI, lateral MI, inferior MI, and so forth. From that, you must able to identify whether there is a pathological Q wave. So, in normal ECG, a Q wave should be just small and narrow. So, what is a pathological Q wave? Usually, the pathological Q wave, the amplitude is 25% of the succeeding R wave or more than 4 mm. The duration is more than 1 small boxes. That is. So, the duration is more than 1 box, and also the amplitude is more than 25% from the R wave. So this is a pathological Q wave. When the patient has pathological Q wave, it indicates that patient already had an infarction. Means it's usually more than 12 hours post MI. Can be 12 hours, can be 24, 1 week, 3 days, 1 month. You cannot have. Then this is a very popular question. How to see the left? How to tell whether the ECG is left bundle branch block or right bundle branch block? So actually, it's very easy. You just see the left bundle branch block. You just see the shape in Lip 1, APL, and the V5 and V6. In RBBB, we just see M pattern in Lip V1. So I have a mnemonic for you. Just remember this: William and Merrow. So if you see William, WILLIM, mean W shape in the lead V1 and V2, and M shape in the lead V3 or V6, it indicate left bundle branch block. So if you see an M pattern in the lead V1, you will remember right bundle branch block. That is. You see M shape, M stands for narrow in lip V1. We will indicate right bundle branch block. You will see William W shape in lip V1 and M shape in V5 and V6. William, you must remember left bundle branch block. It is actually very easy. So why bundle branch block is important? Because if patient who presented with sudden onset of chest pain and not known to have previous ECG of right or left bundle branch block, you must assume that the patient has acute anteroseptal MR. So I'll come to the next topic, how to classify arrhythmia. So arrhythmia is very easy, whether it's fast or slow. If slow, we means the heart rate is less than 60, we define them as bradycardia. So if the heart rate more than 100, we classify them as tachycardia. So in tachycardia, there will be another division, narrow complex or broad complex tachycardia. So narrow complex means the QRS complex less than 3 small boxes. There's a further divided to whether atrial flutter, supraventricular tachycardia or sinus tachycardia. If the QRS complex more than 3 small boxes, we call it broad complex tachycardia, and it's either ventricular tachycardia or ventricular fibrillation. For bradycardia, there is heart block or simple bradycardia. So what is the sinus arrhythmia? Sometimes when I do run, I just comment the ECG. Okay, the rhythm is sinus arrhythmia. So means sinus arrhythmia, there will be a beat-to-beat variation according to the patient inspiration and expiration. It's usually occur in patients who are extremely young or extremely old, or in athlete, where their vagal tone is very prominent. So during inspiration, usually our heart rate will be increased, and during expiration, our heart rate will be reduced. So there will be a variation of the RR interval according to the patient inspiration and expiration phase. So bradycardia can further divided to sinus bradycardia and heart block. And heart block can further divided to first degree heart block, second degree heart block, or complete heart block. So if the PR interval less than 3, but the RR interval or the heart rate is less than 60, we call it sinus bradycardia. The order of sinus bradycardia will be intrinsic cause or extrinsic cause. So the intrinsic cause is acute ischemia or infarction of the sinus node. This one will be the degenerative disease or chronic degenerative changes like fibrosis of the atrium and also the sinus node. Extrinsic cause that we must identify when we encounter patient with sinus bradycardia, we must make sure that patient is not in the hypothermia. Let's say if you go to a cold country or you go to Arctic expedition, you suddenly or you go climb the Mount Everest, you find somebody unconscious and you do an ECG, probably the patient will have sinus bradycardia. Or you see someone in the clinic, you see that they have sinus bradycardia, you must make sure that you take the serum thyroid function test. Make sure the patient don't have hypothyroidism. Of course, you must diagnose them clinically. You must examine their reflex, make sure they don't have the slow racing reflex. You must look at their eyebrow, touch their hair, to make sure they don't have the specific characteristic of the clinical sign of hypothyroidism. So you must look through the patient medication. Make sure the patient is normal for the patient who taking beta blocker or digoxin or certain anti-arrhythmic drug to have sinus bradycardia. And also you must make sure the patient will have this newly mediated syndrome like carotid sinus syndrome, vasovagal syncope, and POTS. This one will be explained. We will discuss in the next lecture about syncope. So what is first degree heart block? First degree heart block is still very easy. Usually the heart rate will be less than 60 or sometimes can still be more than 60. But the PR interval, as you all can calculate here, the PR interval will be more than 5 small boxes or 0.22 seconds. Usually I always emphasize just the numbers of boxes so that you all can remember well. So you must calculate the number of small boxes or the PR interval will be more than 1 big boxes, means 5 small boxes. So the numbers of the PR interval is 1, 2, 3, 4, 5, 6, 7, 8. Almost 8. Means the PR interval is prolonged. So you must diagnose the patient as first degree heart block. First degree heart block, what should we do? Usually we don't need to do anything. We just monitor the patient. Unless if the patient has symptom of bradycardia. Usually it occurs in elderly people, part of the degenerative disease. Then also with second degree heart block. Second degree heart block can further divided to Morbis type 1 with Baqlish phenomenon or Morbis type 2. Morbis type 1. Morbis type 1, there will be a prolongation of the PR interval. Then the subsequent PR interval will be longer from the initial PR interval. Then after that, there will be a drop it. Then it will repeat it again. Morbis type 2, there will be a fixed block. Let's say here is 1, 2. So at every 2 QRS complex, there will be a drop in the QRS complex. And this is a 2 to 1 block, part of the Morbis type 1. But some people say 2 to 1 block, you cannot classify it to the Morbis or Morbis 2 or Morbis 1 because there is no other QRS complex to compare. Because in Morbis type 1, we can compare this QRS complex with this QRS complex and this drop. In 3 to 1 block, you can compare. There's the PR interval is similar, then after that it will drop. So in 2 to 1 block, some people they classify it as a different entity under second degree heart block. So the risk progression to complete heart block is higher Morbis type 2, and usually it's indicated for permanent pacemaker. In case of acute MI with secondary heart block, it usually can be found in patients with inferior MI. We just need to monitor whether patient have any symptom. If patient don't have any symptom of bradycardia like giddiness, loss of consciousness or in heart failure, we must consider to insert a temporary pacemaker, or if the heart rate less than 30. Anything less than 30, you need to, if you are in the district hospital, you must refer for a temporary pacemaker. So in patient with anterior MI, there is a high risk progression to complete heart block. So usually in patient with anterior MI, is involve the Purkinje fiber. We need to put a temporary pacemaker followed by a permanent pacemaker. So this is an example of complete heart block. So in complete heart block, there will be a AV dissociation. Means every Q wave will not followed by QRS complex. the P and QRS complex will be independent. So like you see here, there's a P wave here, probably a P wave embedded here, P wave here, P wave here, P wave here, P wave here. So P wave and QRS complex is dissociate. Then there's the QRS will be on its own. Usually in patient with complete heart block, the QRS complex will be broad because it originated from the ventricle, not from the SA node. So these are the etiology of complete heart block. Can be congenital, can be happen in a newborn. A patient can born with complete heart block. So usually what we do for patient with congenital complete heart block, we ask them to run on a treadmill. Then if the heart rate increase with exercise, we just monitor them. No need to put a pacemaker. There are other causes of complete heart block. Hydropotic. The commonest one is hydropotic fibrosis, ischemic heart disease that I mentioned just now. Sometimes I still see a lot of patients with infiltration, especially the amyloidosis and sarcoidosis, rarely neoplasia, post cardiac surgery, especially after aortic valve surgery. Drug induced, mostly very common. Sometimes they just the old people who on digoxin or amiodarone, they just presented with symptom of bradycardia that we do ECG. There will be a complete heart block. So what we do, if the patient don't have significant symptom of bradycardia or not in failure, we just monitor them in the ward. Right? Usually after the drug wean off, the patient heart rate will be improved. Or sometimes if the patient is very symptomatic, we can insert a temporary pacemaker. Then we try to off the pacemaker after 72 to more after 72 hours. Sometimes then if it's persistent, then we have no choice. We need to insert a pacemaker, permanent pacemaker. Infection, some infection like endocarditis, which involve aortic valve, because our His bundle anatomy is very nearby to the aortic root. So if any infection to the aortic valve can cause active valve abscess, and patient can develop complete heart block, lung disease or Chagas disease, and sometimes in patient with SLE or rheumatoid arthritis because of their myocarditis, so they can develop complete heart block. So management for complete heart block, if patient, we think the patient have persistent complete heart block and is irreversible, usually we need to insert a pacemaker, permanent pacemaker. So supraventricular tachycardia means tachycardia originated above the his bundle. So it will be divided to sinus tachycardia, AVNRT, AVRT, atrioventricular nodal re-entry tachycardia, atrioventricular re-entry tachycardia, atrial fibrillation, atrial tachycardia, or multifocal atrial tachycardia. So this is an example of supraventricular tachycardia. So if people ask you about this ECG, if you don't know about how to differentiate between the AVNRT, AVRT, atrial fibrillation, you just say the patient have supraventricular tachycardia because it's narrow complex. So you are at least 50% correct. Most of the time, small narrow complex tachycardia is not life threatening. So we can try if this you maneuver, can try vagal maneuver, use your finger to carotid massage, or you can ask the patient to do Wasaba maneuver, ask them to close their nose and blow until you hear their ear pop. Or if the patient is hemorrhagically stable, you can try to give IV adenosine, 6 mg adenosine. Then after that, give another 12 mg, or if still not reverted to sinus, you give another 12 mg. Need to use a IV line that close to the heart, whether from the brachial or at the neck, big ball. Then you must, after you give adenosine, you must flush with a 20 cc normal saline, because the half-life of IV adenosine is very rapid. And if this measure fail, 6-12 adenosine 6-12 fail, you can give patient IV verapamil 5 mg slow bolus. So the side effect of adenosine, you must aware that patient can develop hyperrhythmia and also bronchospasm. Some people say IV adenosine is contraindicated in patient with asthma, but usually the half-life of adenosine very short. So usually I just give. And if the patient still not reverted after IV verapamil, you can give a DC cardioversion. So in my personal experience, I hardly need to give IV verapamil. I never so far need to cardiovert patient with SVT. Usually it can be reverted by IV verapamil. Most of the time, 99.9%. So when we talk about SVT, we always need to identify the WBW syndrome, Wolff Parkinson White syndrome. There will be a type A and type B. So how to classify WBW syndrome? There will be a short PR interval. The PR interval less than 3 small boxes, and there will be a delta wave. There will be a slur of the delta wave here. There will be a like a bump before the QRS complex here. So we call it delta wave. So it's important to identify WBW syndrome because they can develop the AV NRT and they can develop SVT. If patient have WBW with SVT, we can refer them to electrophysiologist. So the electrophysiologist can do ablation and the patient will be cured from SVT. 99% will be cured from the SVT. So the type A and type B is important because the accessory pathway is from the left side or the right side. It's important for the electrophysiologist, so that they can ablate, they can approach the left atrium or the right atrium to find the accessory pathway. So atrial flutter. So how you identify atrial flutter? Will be a sawtooth appearance of the baseline ECG. Like here, and the heart rate usually in the count of 300. Means 300. If one to one connection will be 300. 2 to 1 connection will be 150, and in this case will be about 1, 2, 3, 5 connection, 4 connection. Sorry, 4 to 1 connection of the atrial flutter. So atrial fibrillation, there will be a irregular RR interval with fibrillation weight at the baseline ECG. There will be atrial flutter, like I mentioned just now. There will be a sawtooth appearance. This one with variable block or multifocal atrial tachycardia. What is multifocal atrial tachycardia? Usually in multifocal atrial tachycardia, there will be also variable RR interval, but you still can identify P wave. But the P wave will have 3 different morphology. Example, the morphology of the P wave here and the morphology of P wave, and this P wave is different. When you see 3 different type of P wave morphology, you can diagnose the patient as multifocal atrial tachycardia. So the causes of multifocal tachycardia almost similar like etiology of atrial fibrillation. Can be cardiac origin or non-cardiac origin. So the commonest cause of atrial tachycardia, atrial fibrillation is ischemic heart disease. A patient with a previous history of acute myocardial infarction. Or patient with valvular disease, especially the patient with mitral stenosis. Or hypertension. Patient just hypertension, and when we do ECG, we can the patient can have atrial fibrillation. So it's very important to palpate pulse of every patient with hypertension, and of course patient with heart failure, patient with sick sinus syndrome. Sick sinus means sometimes patient in atrial fibrillation, sometimes they in complete heart block, sometimes they has SVT. So we call it sick sinus syndrome. They don't have permanent rhythm. They can be in atrial fibrillation, they can be in heart block, they can be in the sinus rhythm. Or patient with pericarditis, infiltrative heart disease like amyloidosis, actually is very common if you in cardiology. Any cardiomyopathy, any problem with your myocardial, post cardiac surgery, myocarditis, and also congenital heart disease. But most importantly, you must also identify that atrial fibrillation can be caused by non-cardiac cause. Example is pulmonary embolism, medication, endocrine problem, thyroid disease. Holiday heart syndrome means after binge of alcohol, after you drink a lot of alcohol, certain medication. If you have electrocution, patient with lung disease, example chronic lung disease, COPD, bronchitis, chest trauma, or even hypokalemia. So in every patient with atrial fibrillation, you must correct the ECG, and you must correct the electrolyte. Make sure it's not caused by the electrolyte imbalance. Then ventricular tachyarrhythmia or the broad complex tachycardia will be further divided to ventricular tachycardia, dorsal lipoa, or ventricular fibrillation. So this one is ventricular tachycardia. So how to identify ventricular tachycardia? There will be AV dissociation. Same like complete heart block, but usually the QRS complex is faster than the P. The P means there will be more QRS complex than the P. Sometimes you can identify P in the appended in the QRS complex. Example here, there will be P in the QRS complex here. So there will be also capture beat. Suddenly you can identify a normal QRS complex in the patient with broad QRS complex. Then suddenly there will be a capture beat. So if you see this kind of ECG, just tell them this patient, confidently say that this patient has ventricular tachycardia. Or you can sometimes have fusion beats. That means there is a fusion of the broad complex tachycardia and the broad complex QRS complex and the narrow complex tachycardia. So instead of very broad QRS complex, there will be a slightly broad QRS complex, but not really normal QRS complex. So we call it the fusion beat. So usually there will be a extreme axis. Means if the QRS complex is positive, all will be positive. If the QRS complex is negative, all will be negative. So it will be suggestive of VT. Or in B1, if we want to compare with the RBBB, usually the RBBB, the right rabbit ear is taller. But in VT, the left rabbit eye is taller than the right rabbit eye. So if you see taller left ear, means it's usually always a VT. So these are the causes of VT. Most commonly due to ischemic heart disease, acute MI or previous infarcted muscle. The VT originated from the scarring myocardial for patient with valvular heart disease, especially aortic stenosis, patient with cardiomyopathy or heart failure, and they can develop VT. Like atrial fibrillation, electrolyte is always important. You must make sure there is no hypokalemia and hypomagnesemia. That's why every patient in CCU or patient who had acute coronary syndrome, you must make sure the potassium is more than 4 and the magnesium is more than 1 millimole per liter. And certain drug also can cause VT. And so this one is ventricular fibrillation. I mean the ventricular is just fibrillating. It's just not contracting, it's just fibrillating. So usually in ventricular fibrillation, the rate cannot be determined. And when you feel the pulse, usually there will no pulse. And you cannot feel any wave, and there's no PR interval, and there is a bizarre QRS complex. So what you do when you see ECG like this, you should shout for help and start CPR. Tosalipoa is we call it I forgot the term. So means there is a changing in the axis of the QRS complex. Sometimes it's positive, sometimes it's negative, like a party spiral. Sometimes when you do a birthday party, you take a ribbon and then you make a spiral. We call it party streamer. Then the cause of tosalipoa is usually caused by prolonged QT. What is prolonged QT? Means the QT interval is prolonged. So what is normal QT interval is different between man and woman. So if how to remember it? Usually I remember like this. Man, if the normal QT is less than 440. So you just remember the Chinese people, they hate number 4. So if more than 4, patient can mati lah, can die lah, can develop tosalipoa. And women, they always want more than men. So in women, you just add another 20, make them happy. Or if you have your calculator, you can open your QXMD. You just open the how to calculate the QT interval. You just fill up the numbers of small boxes from the Q to N of T. So then the calculator will calculate for you the corrected QT interval. So these are the causes of prolonged QT. Like I mentioned just now, hypokalemia is important. Electrolyte is very important in cardiology. You must correct all electrolyte imbalance in patient who has ACS or in the ward. That's why if you notice this, your MO or the specialist always concerned about hypokalemia or hypomagnesemia or hypocalcemia. So you must correct all the electrolyte imbalance because it can cause prolonged QT, and prolonged QT can lead to tosalipoa. Hypothermia, patient with MI, post-cardiac arrest, patient with raised intracranial pressure, or patients who are born with long QT syndrome. And most importantly, certain drug can cause prolonged QT syndrome. What drug that cause prolonged QT syndrome? Sometimes Dr. Nizam will call me because his patient on, let's say, on haloperidol or quetiapine because of schizophrenia, let's say, they can develop prolonged QT. Sometimes we can psychiatric patient in what can develop VT because they have prolonged QT syndrome because of the drug. Certain antidepressant, antihistamine, the cough medicine that you prescribe over the counter can all cause anti-arrhythmia or certain medication, common medication like quinine, antibiotic like erythromycin. This is there are common drug that you all use in your daily practice, especially like here, Loratadine is very, very common. We prescribe it over the counter. So So all this drug can cause prolonged QT. So if you must be careful when you want to give patient with this medication, if especially if they are high risk. Patient have previous ischemic heart disease, patient with heart failure. So if you want to give this kind of medication, you must at least do a 12 leads ECG. Make sure they don't have prolonged QT syndrome. So I guess this is my slide. I will open for any question. Any question?
Thank you, Dr. Baqlish, for a very enlightening sharing on ECG. A lot of stuff, I'm sure, for most of us, but those are important, pertinent information with regards to ECG. So we open for any questions from audience, if there's any. Take this opportunity to ask questions directly to our speaker, Dr. Baqlish. Anybody with any questions?
Malu eh. Don't worry, you don't need to open your video. You can just ask or you can use the chat to ask question. I think I don't know. Okay, Khatijah.
I'm Tija from UAE.
Hi, Khatijah.
Okay. Thank you, Doctor, for the explanation. So I would like to ask about, is there any high lateral myocardial infarction?
Sorry?
High lateral myocardial infarction.
High lateral myocardial infarction.
Yes.
What do you mean by high?
I mean, if from the ECG, for example, from the there is a ST elevation at the lat 1, AVL, V5, and V6. So can we consider it as a lateral MI, or we just see it as a lateral infarction?
I'm not sure if we have any definition for high or low lateral MI. So lateral MI is just, for me, it's just a lateral MI. So if there's a ST elevation in one AVL or V5, V6, any two consecutive ST elevation in this four lead, we just diagnose them as a lateral MI. Usually lateral MI caused by a OM branch, obtuse margin branch of the circumflex artery, the OM1 or OM2. So probably what you mean, probably the OM1, but I'm not sure. Most of the time I just use lateral MI. I hope I answer your question.
Okay, there are a few questions on chat section. Can Dr. Baqlish view the question? Can you see the question?
Flecainide not easily available, but we do use. Dr. Kelvin is one of the research assistant in our cardiology unit in Universiti Malaya. So sometimes we use lah. It's available in Universiti Malaya, but many other centers don't have Flecainide, and it's quite expensive lah. So another question by Nish Awa. Can you explain more about the ECG for inferior posterior MI with RV involvement, especially the interpretation of the right-sided ECG? So let me open this one. So in patient with inferior MI, I got a lot of this ECG, ECG presentation. This one, right? So RV involvement means if you do right-sided ECG, you must look at the V4, right side V4, V5, and V6. How we do the right-sided ECG, you must look at the lead V3, V4, or V5, V6. There will be, if there is ST elevation, more than one small boxes at the lead V3, 4, or 5, or 6, mean there will be a RV movement. So in 12 lead ECG, if you see there is any tall R in the lead V1 or V2 or V3 with ST depression in the lead V1, V2 or V3, you must suspect the patient have posterior ECG. So you must do the posterior ECG, the lead V7, V8 and V9. Then if there is a one box ST elevation of the lead in the lead V7, V8 or V9, then we say that the patient also have posterior ECG. So usually the inferior posterior MI with RV movement usually occur in the proximal RCA infarction or proximal circumflex infarction, depends. Because in our coronary artery, there will be some people who has artery dominant or left circumflex dominant. So usually inferior posterior MI with RV movement occur in patient with left dominant, the circumflex dominant coronary artery and the proximal circumflex. So because the in patient with dominant circumflex artery, the what we call the branch. Suddenly I got blocked. One of the branch that supply the posterior wall is originated from the circumflex vessel instead of the right coronary artery. So this kind of patient, they can develop inferior posterior MI with RV involvement. Is it safe to treat SVT with aberrancy SVT by giving amiodarone? Actually, you can give SVT with aberrancy with amiodarone, but problem sometimes patient can develop complete heart block, especially if the patient have WPW. Any other question? Yes, JS SVT. So the SVT with aberrancy sometimes you can misinterpret as VT. So you must careful. SVT with aberrancy means the patient has a left bundle branch block or right bundle branch block, but they develop SVT. So if you want to discuss about SVT with aberrancy, is another long lecture. But in short, you must treat as SVT. And you must able to identify the VT that I mentioned just now. Any other question? If there is no question, probably we can close the session. Nizam? Oh, Nizam already left the meeting. If there's no question, probably we end this question. I hope you all benefit from the lecture just now. Let's say if you all meet me somewhere, please say hi to me. Okay, I will end my video sharing. Good luck to everyone. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Baqlish. All right. Thank you, everyone. So, inshallah, we will post the recording on I-Medik Facebook, and I email to everyone the recording as well. Thank you.